we get started, Molly? And as we're doing introductions, some more folks will join, and then that way we stay on time.
Okay, perfect. Sounds great, James. So first of all, thank you everyone for joining us today. James and I are very excited to be here. We're going to be talking about insomnia. I think this is an area with a lot of interest, and it's not one that we get a lot of innovation in, so it's super exciting when we get to talk about a new product in this market. So we'll go over the treatment of insomnia, the new offering, and then highlighting some resources that are available for pharmacists and for patients as well.
So I'll just start with a few introductions and notes about today's presentation. So introducing myself, I'm Molly. So I'm James Morrison. I am Director of Pharmacy Excellence with Whole Health Pharmacy Partners. I provide operational support for our 100 pharmacies across the country in British Columbia, Alberta, Saskatchewan, Ontario, New Brunswick, and Newfoundland. So if you're interested in Whole Health Pharmacy Partners, definitely send me an email. Happy to answer your questions. One thing that Whole Health likes to do is provide education for our pharmacies and also other pharmacists out there across the country. And that's part of what Molly does in her role. So Molly is a Doctor of Pharmacy recent graduate from U of T, and was actually an intern with Whole Health, and we're very pleased, and even a student before then. So we're very pleased Molly is sticking around for a while and taking on a full-time role as pharmacy marketing and professional affairs specialist. So I'm very excited, Molly, for the presentation tonight.
Okay, thanks so much, James. Awesome intro. And I'm excited to be here with you this evening as well. And just before we begin, a little bit of a disclosure. We just want to thank Isai, and I know that Michelle and Sean are on this call. Just a thank you to make the development of this webinar possible. Going into our agenda for this evening, so we're keeping it focused on pharmacy perspective and try to end it at a timely manner as well. So we'll try to go throughout the whole presentation, and then if you have any questions, feel free to put them in the chat box and we'll address them at the end just to make sure we have enough time. In terms of the agenda, we're going to be going over an overview of sleep and insomnia first, followed by the pathways involved in insomnia and the new product Dayvigo, and then going into how we can actually integrate it into our pharmacy afterward. So starting with an overview of sleep. So something a little bit fun before we get started, busting some sleep myths, addressing some misconceptions about sleep. So number one that we have here is that benzodiazepines are effective in the long term for insomnia. So we know that benzodiazepines work really well at sedation in the short term. But how common do you see in your patients taking long-term benzodiazepines for insomnia, where often these patients may have started on a different dose and they may have escalated, which is shown by this graphic here, or perhaps they're finding it difficult to stop this medication now. So we know that there is a rapid tolerance when it comes to the effect of benzodiazepines when it comes to sleep. And it's also, there's a lot of dependence on this medication as well. So we know benzodiazepines aren't the best in the long term, but what about Z drugs? Are they any safer? So we know that Z drugs and benzodiazepines kind of have the same effects, and they have the same side effects as well. So they both work to increase sedation and result in daytime sedation. They result in increased risk of falls due to postural instability and that sedation, daytime impairment and impairments in driving, and of course, very significant cognitive effects, especially for our older patients who take them in the long term. Another one that may commonly come up, can you train yourself to sleep less? Even though some people may claim to be able to, we do have a biological imperative to sleep. So sleep is really, really essential for all levels of our health. Humans spend roughly a third of our lives sleeping, and there are genetic determinants when it comes to our sleep requirements. And although there are different sleep requirements as we go through different stages in life, the point is that it is extremely rare for someone to be able to function well on very little sleep. Okay, so going forward, what is insomnia? So there's a difference between insomnia symptoms and insomnia disorder. Although we know in the pharmacy, sometimes these lines get blurred as to who gets treatment. Although typically to be diagnosed with insomnia disorder, they need to meet these criteria. So number one, difficulty initiating or maintaining sleep that occurs 3 times per week for at least 3 months, along with daytime impairment. And these things have to occur despite adequate opportunity to sleep, and also not explained by other medical conditions. So that being said, how are Canadians affected? So sleep disorders or sleep issues are highly prevalent. And as we just mentioned, there's a difference between actual insomnia symptoms and insomnia disorder. And of course, we know just how common disrupted sleep is, especially with our patients. We hear it all the time, and over 1 in 3 Canadians experiences the symptoms of insomnia. So this study was done in 2011, where they found that 13.4% of Canadians met all the criteria that would need to be diagnosed for insomnia disorder. However, looking at the same population, 40% of Canadians met at least one symptom of insomnia disorder. And this was done in 2011. And of course, we know the pandemic has really exacerbated almost all health issues during this past year. And we have recent data that's emerged from the pandemic where we know that COVID has impacted both our sleep and our mental health. And these are related to stresses related to the pandemic. So it could be financial, could be checking the news, could be family, health related. Disruption in our schedule and social distancing has led us to have more time and electronic use, which affects our sleep. And then also it can be related to profession as well. So commonly healthcare professionals are more affected with mental health and sleep. So this is not only important for our patients, but also for ourselves.
Yeah, that's a really interesting point, Molly. Since we started promoting this webinar, I've actually had pharmacists reaching out and letting me know that they are suffering from insomnia during the pandemic. So it's a very timely presentation.
Yeah, definitely. It's certainly very striking just how prevalent this is. And so speaking of the prevalence, what's the actual impact for patients who experience insomnia? Again, sleep impacts all systems. It's not just our physical and mental health that can be impacted. It also impacts our productivity, our satisfaction with our lives as well. We really can't have wellness without having proper sleep. So comorbidities are highly prevalent, especially with the mental health part. So there's a lot of depression and anxiety that are comorbid. All of these factors are interrelated as well. So then when you throw insomnia into the mix, it can snowball and feed back. So in terms of complications with physical, there's cardiovascular, cerebrovascular, metabolic issues. Attaining sleep is also getting to that deeper level of sleep is essential for tissue repair and restoration and to maintain a healthy immune system. There's the mental health part that we just talked about. It also impacts learning. So another stage of sleep is the REM stage, so rapid eye movement stage, which is a lighter stage of sleep. And this is where you get all those vivid dreams. But this stage is really important for consolidation of memory and for learning as well. And in addition to those, sleep can contribute to accidents and also impacts your productivity. So there's absenteeism, which is time away from work, and presenteeism. So perhaps you go to school or work and you're not at your 100% productive. So that's what the effects on productivity are there. So going into sleep pathways. Okay, so we're going to spend a couple minutes on this slide. It's a simplified model, but it kind of shows the connection between GABA, orexin, and sleep. So we're all, I think, very familiar with GABA in the fact that increased GABA works to reduce the activity in our neurons. So both benzodiazepines and Z drugs here act on this receptor to induce this sedating pathway, which kind of tips the seesaw over to this sleeping side. On the other side of the seesaw, we have orexin. So orexin is made up of orexin neurotransmitters, orexin A and B, which work on orexin 1 and 2 receptors. So these actually are also involved in the sleep-wake rhythm. They are also involved in feeding, reward, and energy as well. And the downstream effect of this pathway is that it's promotes and sustains wakefulness. So kind of tips the seesaw in the other way towards this wake side. So as we said, both of these pathways are involved in this balance, and the drugs that we have act on these different pathways through different ways, but ultimately both of these will work to promote sleep. So it's an interesting change and transition here in that we've always considered sleep to be an issue of not enough sedation and not enough GABA, which is reflected in the medications that we use for it, right? By increasing GABA. It's what we've always traditionally used for sleep. Whereas here with the orexin antagonists, we're working on this other side where we're changing how we view insomnia as an issue of hyperarousal as opposed to not enough sedation. Okay, so on the left side here, just to give you an example of what an appropriately functioning and regulated sleep cycle would look like. So on the top, very top, here we have sleeping time with the little moon here. And in a normal person, with an appropriate signaling and regulated sleep-wake cycle, we have appropriately elevated GABA signaling sleep here. And the orexin here is quiet. And on the flip side, when it's daytime, we have increased orexin signaling and lower GABA. Okay, so what happens when we have inappropriate and excessive orexin signaling? So even though at nighttime here, the GABA is increased, this person who has an overexpression of orexin at this point, it can tip the scales over, so then even though there's GABA, there's still difficulty attaining that sleep. So in the past where we would have used GABA agonists here, even though we increase the GABA, which may bring the patient over to sleep, we do run the risk of oversedation and too much GABA as well. So that's where orexin antagonists come in this situation, and they're able to decrease the signaling in orexin to bring the patient closer to what a normal and appropriate signaling sleep-wake cycle looks like. And the benefit here as well is that orexin is less, it's more targeted, so it's less widespread than GABA, so we may expect less of the side effects that we commonly associate with GABA agonists. Okay, so this slide kind of goes over some of the options that are available benzodiazepine agonists. So in the box here, we have benzodiazepines and Z drugs. Now, although these are indicated for sleep, a lot of them are not recommended. So the only one is really temazepam, which can be used for both onset and maintenance. We also have Z drugs over here, so zopiclone and zolpidem, which I'm sure many of us are familiar with. There's also esopiclone, which is relatively new in the market as well, Lunesta. It may be a little bit better tolerated, but it's still a Z drug and it is still subject to the prescribing limitations of 7 to 10 days and short-term use only related to benzodiazepine agonists. And of course, we've kind of already addressed this as well, but there are adverse effects associated with benzodiazepine agonists. So there's the rebound insomnia, the falls and fractures from daytime impairment, the accidents, the cognitive and memory issues, especially in long-term use for our older patients, the daytime sedation, which can really affect quality of life, motor deficits, which can affect independence, and of course, tolerance and dependence. And it's really important when bringing this up with patients who are on long-term benzodiazepines that it's important to point these out because one, they might not be fully aware, and it's important for buy-in and for reasoning as to why you want to deprescribe as well. So on the flip side, we have the dual orexin antagonist. The only one that's on the market in Canada is lemborexant. So the trial data from lemborexant shows both objective and subjective measures were improved with lemborexant. And so they measured things like sleep onset and maintenance and total sleep time. There's also subjective evidence with improvements in sleep quality as well. And these trials compared lemborexant to both placebo and zolpidem. So it is safe for older adults. The trial data looked at adults from 18 to 88 years of age, and there was no evidence for there is evidence for short and long-term use of this medication. So the data went up to 12 months, so it can be used in chronic insomnia every day for up to 12 months as per the data. It is also, another benefit is that it is also better at maintaining sleep than benzodiazepines, which is something that may be more important for our elderly population as well. In terms of common adverse effects with this medication, we had somnolence, which is drowsiness, and this is part of the mechanism of the drug. There was dose-related daytime drowsiness as well, although this translated to very minimal daytime impairment. In terms of other common adverse effects, there's headache, nasopharyngitis, and fatigue. These are all more common with the higher dose. Additional notes, so there's a low risk of falls, and this is due to so they assessed this with a study looking at postural instability. There's also no tolerance with this medication, so the effect was consistent throughout the time taking this, up to 12 months. No next day driving impairment, and no withdrawal or rebound insomnia, even after taking it for 12 months regularly.
So Molly, before you move on, I think I'll ask the question because it sort of relates to that slide.
Yeah.
So how long does a patient have to take Dayvigo before it starts to work? I have a patient that has been taking it for 2 weeks now, and it hasn't helped her sleep yet. So is it time to try something else?
Yeah, that's a good question. I think looking at the trials, there was an effect seen in most patients by days 1 and 2, and especially by week 1, there was an effect seen. So in the case where the patient is not seeing any effect from it, perhaps it could be about maybe going up to another dose or trying something new in that scenario.
Great, thank you.
Okay, so what can pharmacists do with all this information now and with this new drug on the market? So number one, we have the most regular contact with our patients, and we know when these patients are filling their medications. So we have a lot of opportunities in pharmacy to optimize management for insomnia. So number one would be to assess and optimize their chronic medications and see if there's anything that's contributing to their insomnia. After that, we can see if they're taking benzodiazepines inappropriately, if they're taking them in the long term for insomnia, then it would probably be best to deprescribe and recommend that. And then number 3 would be to recommend alternatives. And it's important to have clear counseling and education about insomnia throughout. Okay, so as for optimizing medications, so I put this slide together just as a reference for things you might look out for when you're assessing whether or not a medication or a condition is affecting their insomnia. So this is a chart of common medications that can cause insomnia. You also want to consider conditions as well. So is it pain? For example, chronic pain conditions like arthritis can cause insomnia. There's also neurologic issues like Parkinson's and restless leg, endocrine issues like hyperthyroidism, mental health disorders, of course, and structural things like obstructive sleep apnea can all affect their sleep. We also want to consider non-prescription factors, so things like caffeine, which is present in a lot of things. Often patients don't have the clearest idea of how much caffeine they're intaking, because it's not just in coffee, it's in tea, energy drinks, pop, sometimes in decaf as well. There's also nicotine, which is of course a stimulant, and alcohol. So although we know alcohol may be immediately sedating, it's shown that in the latter half of the night it is actually bad for sleep and it can disrupt your sleep. Okay, so deprescribing BZRAs. The number one priority here is to make sure the patient feels supported. So developing a clear schedule for the patient will help with buy-in, and it makes the patient feel supported. They had something to refer back to when they're not at the pharmacy, you're not in front of them, and maybe they're struggling with cutting down on their dosage. Another thing to note here that it's really important to be collaborative as possible. It's really hard for patients to buy in when they're hearing different messages come from different parts of their healthcare team. So whenever possible, being on the same page about deprescribing. And why deprescribe? I think we've talked about this throughout the presentation, but it really comes down to the risk versus benefits of taking long-term benzodiazepines. So for example, like there's both efficacy and safety. Efficacy, we know there's tolerance in as little as 4 weeks, and it's only useful in the short term. Safety, we know that there's risks and compounded risks with continued use. This is relating to the tolerance effect as well, where it's been noted that a year after deprescribing and stopping a benzodiazepine, patients may expect to experience similar sleep quality, which really goes to show perhaps how little the benzodiazepine was helping them at that point. Just wanted to make a note here that there are, of course, appropriate uses of benzodiazepines. And in this presentation, I'm only referring to insomnia that is independent or insomnia that with comorbidities that are appropriately managed. So in circumstances where there's other comorbidities such as panic disorder, anxiety, alcohol withdrawal, so these are situations where it is still appropriate to use benzodiazepines. Okay, so who are we actually looking for deprescribing, and how can we do this in the pharmacy? In terms of who we're looking for all seniors who are using benzodiazepine for sleep. You know, benzodiazepines and Z drugs, they're on the Beers criteria. No seniors should really be on this for sleep. We're also looking for adults under 65 if they're using benzodiazepine agonists for over 4 weeks, because again, as we said, so at refills, so looking for problematic use, so especially if the patient is requesting an early refill or if there are multiple prescribers, that is a trigger for you to investigate further. Also, for example, if it's a discharge and perhaps the patient got started on the benzodiazepine in the hospital for sleep, but now they don't need it anymore. So kind of every time you see a benzodiazepine come up, looking more into it, are they using it for sleep, and is it appropriate and effective still? We can also assess during medication reviews or counseling. So even though you're not there for the initial fill or for the initial prescription, if you do see the benzodiazepine on the patient record, then asking more questions. If they're using it for sleep, how long they've been using it, is it working, and how often they use it as well. We can also look for patients using our pharmacy software, so on Kroll and Philware. You can make reports that filter patients based on various medications. And here I've just included the Insomnia Severity Index, which can help when you're assessing the severity of insomnia. And just a note here that these slides they can be sent to you at the end of the presentation. We're going to have a survey at the end, so if you'd like to fill it out and just indicate that you're interested in getting the slides, we can provide those for you.
Yeah, Molly, before you go on, I have a question that relates to that slide, and it's quite long, so now bear with me while I read it out. Thank you for the question. So it is well known that benzos are meant to only be used short-term for insomnia, but the majority of physicians prescribe them with multiple refills, i.e. for long-term use. Are you able to share any strategies from your practice about what you would do when you intercept these prescriptions, i.e. would you just counsel the patient about short-term use and reassess with them, or do you reach out to the prescriber? If it is the latter, that could be a job in itself. Also, moving forward, how do you plan on communicating to physicians about switching Dayvigo? I'm sure most of my colleagues can relate to the fact that we all have tons of patients using benzos long-term inappropriately. Thus, I'm curious if my colleagues plan on running some sort of list to refer these patients and then send recommendations for them all at once to the prescriber. I work in long-term care, thus very excited about Dayvigo for the elderly population. Thank you for the question. Molly, I'm going to take a stab at that one.
Okay, yeah, thank you so much. I think definitely agree with your points on the question. It is a multifaceted question, so I'll try to answer the different parts of it. In terms of how to address these situations when they come up. It is very difficult, especially working in community when we don't have the full picture and we get a prescription where we don't exactly know maybe what the indication is for. And that's why it is really important to kind of talk to the patient, ask them if it is due to insomnia. Then, of course, we have the data to back it up, that it should only be for short-term use. In terms of speaking to the physician, as a part of this webinar and this program, we've also developed some pharmaceutical opinion templates that clearly state why we would recommend deprescribing a benzodiazepine and switching to lemborexant as well. And those can be made available as well if you just indicate your interest in the survey at the end as well.
Yeah, the question on approach, whether you just run a report and do your whole database all at once, I would probably do a phased approach, like little by little, and transition folks over time. So, you know, you can monitor each of the patients a little more carefully because a benzodiazepine crossover, and I think you're going to cover it in this presentation. There's different ways to do it, but I would want to make sure that I was available to monitor the patients. So I would probably, you know, go in phases rather than everyone all at once.
Yeah, I agree with you on that point here, James, just because, you know, we're aiming to move in the right direction here, and it doesn't have to be all at once. As long as we have some plans in place to kind of address this as they come up. Of course, there's the issue with capacity if we were to go and change altogether. There's a lot of monitoring, as James mentioned. So definitely take them as they come, and when possible, making those changes and making those benefits for the patient. Okay, so this is an example of a taper schedule. So we had mentioned in a previous slide how important it is to provide the patient with a schedule that they can refer to when they're not in your pharmacy. So on the left here is an example from the Empower brochure, and this is in part developed by deprescribing.org as well. And I've just linked the brochure here. It includes this schedule, and it also includes a bunch of other patient-friendly resources as well. And just as a note, there's no superior schedule that has been identified. So they don't have to, I mean, you don't have to give this, you can provide your own schedule as well. The important thing is to go slow, as slow titrations are more effective. So you would want to be doing 10 to 25% decreases every 1 to 2 weeks. You may also need to reduce by less or by longer increments in the last quarter. So within the last quarter, that's when most of the withdrawal symptoms start to show up. So when they're at 25% of their baseline dose, that's when you maybe want to be a little bit more flexible, go a little slower, go down a little bit by a little bit less. There was also recommendations in the past of switching to a long-acting BZRA like diazepam to help with titration. However, the evidence behind that is not super supportive. So it might just be better just to titrate patients on the drug that they're currently taking. And there are additional resources at the bottom there too. So in terms of withdrawal, unfortunately, these can and likely will occur, especially if you're replacing the benzodiazepine agonist with, if you're not replacing the benzo with another medication. So these are usually mild and get better within within days to weeks. And I think the important thing on this slide here is to make sure patients are aware that these things will happen so that they don't get discouraged when they do happen. And it's also important that patients know that it's also flexible. So when these things do happen and they're bothersome, they don't feel afraid to come to you and talk to you about them. You let them know that it's okay to slow down the titration a little bit more. Perhaps we hold the dose for 1 to 2 weeks and then continue slower. In terms of coverage for deprescribing, unfortunately on the provincial side, there's not a lot of coverage that we can really go to. But on the private side, Green Shield Canada offers a deprescribing program with their extended health and drug benefit coverage. So the eligibility criteria is very similar to that for general deprescribing, which we had discussed in a previous slide. And you can see on the left here, this chart kind of shows down a breakdown of what you can bill as a pharmacist. So you can bill up to 5 interactions, starting with an initial assessment, followed by 3 follow-ups, and then the final follow-up. And based on the agreement or no agreement or a change in therapy or not, there's different tiers as well. So the maximum amount would be $70 per patient per year. There are some documentation forms that are required that you can access here. And just to note that it's important to remember that a reduction in dose is a win as well. So again, remembering to be flexible, going along with the patient and adapting to what they may be experiencing. Okay, so this slide goes over some of the alternative medications that are indicated by Health Canada. Unfortunately, no provincial coverage for these, although we do know and are excited that ESI does have plans to submit to provincial plans, but we likely won't see public coverage for this for at least a year or so. We do know that currently lemborexant is covered for a majority of private plans though, so that is an upside. So starting with doxepin, which is a tricyclic antidepressant, the dose is a lot lower than what you'd see for other indications for sleep here. So 3 to 6 milligrams taken within 30 minutes of bedtime. Just important to note that it's only indicated for sleep maintenance. So not indicated for sleep onset, as there's not a lot of benefit for sleep onset. There's also side effects that are listed here, and there is a food-drug interaction as well. In terms of lemborexant, this is again the only orexin antagonist. The dose is 5 to 10 milligrams. In the clinical trials, most patients responded to the 5 milligrams, so that's where you usually start with that. This is taken at bedtime, at least 7 hours before wake, and again, indicated for sleep onset and maintenance, well tolerated. We've gone over the side effects in a previous slide. Just important to note that it is a CYP3A4 substrate, so you would kind of make a note here if patients are on any strong and moderate inhibitors or inducers of CYP3A4. And just additionally as well, there's no renal dosing that is necessary for lemborexant. Just a note about off-label as well. Often we see a lot of antidepressants and antipsychotics used off-label for their sedating side effects for insomnia. However, these come with their own host of side effects as well, and they more likely appropriate for patients with comorbidities. Also, we would avoid over-the-counter options such as Benadryl and Gravol, just because these are also associated with dependence and anticholinergic side effects. Benadryl is, of course, also on the Beers criteria, so would avoid when possible for older adults.
So Molly, before you move on, a couple questions that somewhat relate to that slide, so let's just go back. So the first question is, what are your thoughts about melatonin?
Okay, yeah, that's a really good question. I think it's a little bit of a controversial topic with melatonin, where we have supporters of melatonin and also people who don't respond to melatonin as well. I think that with the evidence that we have in terms of how well it works, there is questionable significance with melatonin. I think the numbers are about 4 to 12 minute benefit in sleep onset. There is, of course, also a placebo aspect to it as well, which can be valuable in patients who are experiencing sleep issues. So if patients do find that they're benefiting and responsive to melatonin, it's generally a well-tolerated medication, so it could be appropriate to continue.
Yeah, I definitely had patients who swore by their melatonin. So whether it's a placebo, as you said, Molly, or an actual therapeutic effect, it's possible. So another question somewhat relates to the slide. So the question's about sundowners. So that's patients with dementia and become agitated or perhaps wandering in the evenings. And those who spend time in long-term care probably see these patients prescribed antipsychotics to help them with that. But I'm wondering, the question's wondering whether Dayvigo's been evaluated in sundowners to help them with sleep.
Yeah, so that's a really good question. I think if it could work in that population, of course, that would be beneficial. However, as per the clinical inclusion and exclusion criteria, and it hasn't really been studied in patients with severe comorbidities such as that. So it is difficult to say at this point with the evidence that we have. Okay, so changing to lemborexant. So we put in the slide because as with any new medications, and we already had a question about it already, there's questions as to how to actually make this transition. So just a note before we begin that the evidence to guide this is based on expert opinion from prescribers and sleep experts. There's not a lot of clinical data, which I'm sure we will see more of in the months and years to come. However, physicians and expert consensus right now is to start lemborexant at the same time as the BZRA is titrated. So the maroon here is the BZRA going down in titration, and you would start when you start titrating that. And this is preferred in patients who are on long-term or high-dose BZRA use. The second strategy we have here is for another patient group. So if patients are not taking their BZRA every single night, then it's fine to just stop the BZRA and then start Dayvigo. So the priority that really guided this recommendation over here is to really support the patients, and especially in ones taking long-term or high-dose BZRAs, we want to make sure that there's something to help support them while they go down, as they're more likely to experience those withdrawal effects, and also for patient buy-in as well. And of course, you want to continue to do non-pharm measures throughout. Okay, so first line, just wanted to put this in here as well because non-pharms are of course the staple for insomnia in their first line. Number one is cognitive behavioral therapy, which is really effective in the long term. And the way it works is it helps patients to reframe their thoughts and feelings about sleep. And yeah, very effective. There's also sleep hygiene, which I think many of us are already familiar with, and we always recommend to patients as well. There's also relaxation and meditation techniques. There's lots of techniques, tools, and apps available now to patients, for example, over their phones, very easy to access. So I think many of us are familiar with the items that come in sleep hygiene and the recommendations, but I just wanted to point out a few. So number one, using a sleep diary. I think this is really critical, especially when titrating a patient down on their BZRA, because this can really help patients have baseline as well. It helps them to recognize triggers for their insomnia. It can also help if they bring it to the pharmacy or they bring it to their prescriber so that we can all have the best picture of their sleep. And there are apps and websites that they can access to easily make a sleep diary as well. Additional sleep hygiene things here, which we all know: avoid lights and electronics in the bedroom, avoiding caffeine and nicotine. There's also this one here: leaving the bedroom if not asleep within 20 minutes and then returning when tired. This is related to sleep restriction therapy and the idea of sleep efficiency, wherein with this, you're trying to reframe your thoughts about the bedroom in that it's only used for sleep and intimacy. It's not the place where you watch TV or you go on your phone. So this is relating to that. So with sleep efficiency, the way to calculate it is your total sleep time over your time in bed, and that'll give you a percentage. And through that, you can give patients a sleep prescription where 85 to 89% is optimal. Over 90%, so if you have someone that is in sleep the second that they fall in bed, that kind of means that they might not be getting as much sleep as their body requires. So the recommendation here would to actually set bedtime a little bit earlier, so 15 to 30 minutes earlier. On the flip side, if their sleep efficiency is really low, so lower than 85, where they find that they lying in bed a lot without being able to fall asleep, even though they may not be getting a lot of sleep, it's kind of counterintuitive here, but the recommendation would be to set their bedtime a little bit later, and that reinforces the fact that when you go to bed, that's time for sleep instead of lying there staring at the ceiling. So for more tools and resources, you can access CA. It links to things like sleep diary, it goes over sleep efficiency and sleep restriction therapy, has links to cognitive behavioral therapy as well. Okay, so this is one of the last few slides. In terms of monitoring patients, as we mentioned, it's really important and critical to monitor patients during this. So at least 1 to 2 weeks at each step during tapering. You'd also monitor anytime you see them basically at next fill, see if there's any changes in dose or therapy, see how their insomnia is doing, and then at next medication review or next visit as well. And every time you want to assess their insomnia symptoms. So this is where things like keeping a sleep diary are really helpful for us as well. You monitor if they're experiencing daytime impairment, withdrawal symptoms, medication side effects. Okay, so we're kind of getting to the end now. I just wanted to point out a couple of resources that we have available. Of course, you can fill out the survey at the end to include your email to get a copy of these slides. We also have, if you're familiar with Whole Health, we make these things called Therapeutics Thursdays. They're kind of like an executive summary of either a medical condition or a program that we have going on. We really try to focus on providing very pharmacy-specific data that's very targeted and concise as well. So this fits in really well with this presentation. We also developed some pharmaceutical opinion templates, as I had mentioned, both for deprescribing and transitioning to lemborexant or New Start for lemborexant. There's also external resources that I talked about during this presentation, and these are linked on this slide. Okay. I just wanted to make a couple of comments. There is definitely a role for pharmacy, and there's a lot that we can do.
Molly, are you still there? We're having some IT issues.
Role for that. Oh no, can you hear me now? Uh-oh.
That's a little better. I think we lost most of your outro though, and then we have a bunch of questions. So
okay.
Maybe try again, and then I'll read you out the questions.
Okay, I was just going on in the background. Okay, so we're coming at the end, but I just wanted to make a comment about how there's a lot that pharmacists can do, both with deprescribing for the benefit of the patient, but there's also, I believe, a stewardship aspect to this as well, where we have an opioid crisis going on all around the country. And if we look at the types of medications and drugs that are being used during these overdoses, many of them are adulterated with benzodiazepines. So it really puts the patient at increased harm. So I think there's multiple layers to this and different directions that pharmacy needs to look at and continue to work at.
Okay, great. So I put into the chat box the feedback link for a survey. So we'd really appreciate it if some of you would fill that in for us so we can be forward thinking about what we might do next. And I'm going to turn to these questions, Molly, of which there's a few. So, what is the time to onset of action if using Dayvigo for sleep onset? So basically, how long before bedtime would you take that?
Yeah, so the recommendation to take Dayvigo would be just at bedtime, a couple minutes right before you go to sleep. The peak is in 1 to 3 hours. So usually patients, again, experience effects within the first or second dose as well.
Yeah, great. And then the next question is this like a daily, like a scheduled drug, or can this be used PRN? That's
a really good question. I think it's really good to point out as well, because in the trials, they were used daily. So both in the month-long trial and then also in the year-long trial, it was used as a daily medication. However, it could also, I see potential role in it being PRN as well, with the data that we have that it does work within the first or second night, and the fact that the peak is within about an hour, 1 to 3 hours, as I previously mentioned.
Great. And are there any contraindications to watch out for with Dayvigo?
Good question. So in terms of contraindications, it's actually interesting because the orexin system in patients who are narcoleptic, so patients who are unable to stay awake, they actually have a deficiency in orexin. And this kind of related to how orexin, like the pathways were discovered and all. So this would not be appropriate, an antagonist of orexin would not be appropriate for anyone who has narcolepsy, in that because they already have a deficiency in orexin.
Right.
And also, just another note that in terms of the studies and the inclusion and exclusion criteria, hasn't really been studied in substance use disorders, and as well as, of course, uncontrolled comorbidity. Not a strict contraindication, but something to consider.
So one person says, Molly, great presentation. I agree. Do you happen to know if Dayvigo modifies the morning cortisol surge? Very specific question. I don't know. We might have to follow up on that one.
Yeah, I'm sorry, I don't have the answer for you right there, but if we can take down whoever asked, then we can follow up with that.
Okay. And a couple more very specific questions around particular patients. So patient with no other complications, tried melatonin, but feeling grogginess next day and having trouble in maintenance of sleep, only getting 2 to 3 hours of sleep. What could be the next option? And they're also asking, where does tryptophan fall as per recommendation?
Yeah, so good questions for both. I think I'll answer the tryptophan question first. So that is kind of another option. It isn't, it's not a Health Canada indication. And the level of tryptophan that you'd have to take, I think, is over 1 gram of tryptophan. So it's high. And again, being kind of like a natural health product, we don't have as much standardization as well. It could potentially be an option for patients if they want to try it. But of course, you're not going to get the same efficacy as you would get with some of these medications that are actually indicated for insomnia. So in that particular patient where they seem to be having a very, very disturbed sleep with only a couple hours of sleep per night, they tried melatonin before. It really is also collaborative effort with the patient and prescriber as well. There are various options that we can use, one of them being Dayvigo. And we do have the New Start pharmaceutical opinion that we've created if you want to use that to communicate with the physician as well. It could be something that they could try.
Awesome. Molly, that wraps up all the questions. Let me just say thank you. I think it's really a very important topic that a lot of pharmacists may not have enough or may not have confidence in, and it's a little intimidating because I've always said that the other options, many of the options for insomnia are not great. Like they're on lists of drugs we can't give to elderly, and we have all these concerns about them. So I was particularly excited to see Dayvigo enter the market here in Canada. I'll turn it over to you if you have any final remarks.
Yeah, I think, James, I echo that as well. And I've talked to other pharmacists about it as well. And I find that we're always frustrated with the options that we have for our patients with insomnia, especially because, as patients age, as they become older adults, their sleep changes. And so a lot of these older adults end up taking benzodiazepines in the short term at first, and then eventually in the long term, which is definitely not the direction we want to be going in. So yeah, I agree. I'm very excited for this innovation and potentially additional innovations in this area.
All right. Well, thank you, everybody. We'll say good night and see you next time.
Okay. Thanks so much, everyone.